Okay, picture this for a second. You're the captain of a massive commercial airliner. You're sitting on the tarmac, engines are humming, and, you're about to take hundreds of people across the ocean. You look down at your dashboard, you've got the altimeter, the weather radar, the fuel gauges. It's incredibly complex. But then the mechanic leans into the cockpit and whispers, "Hey, just so you know, we only check these instruments for accuracy about half the time."
I think I would be getting off that plane immediately.
You and me both.
Yeah.
I mean, it sounds absolutely absurd in aviation, right? But we're looking at a scenario today where that's effectively what has been happening in a very specific, very high-stakes corner of cancer care.
It's a terrifying analogy, but honestly, it holds up. We're talking about the imaging that happens after a woman has been diagnosed with breast cancer, but before she goes in for surgery.
A really critical window.
It is, and until very recently, we've had this massive blind spot in how we quality control those scans.
So this is a deep dive into a study that really peels back the curtain on how radiology actually works, and sometimes how it doesn't. We're looking at a paper out of the University of Texas MD Anderson Cancer Center.
Published in Radiology 2025. It's led by Dr. Ethan Cohen and his team.
And the title is a bit of a mouthful.
It is a bit dry, yeah.
Right.
Feasibility of auditing preoperative breast MRI for extent of disease evaluation using the BI-RADS v2025 manual.
Right.
But don't let that academic title fool you. This is really a story about a major shift in medical safety and how we catch things we used to miss.
So our mission for this deep dive is to understand this new rulebook, the BI-RADS v2025 manual, and how it's changing the game. Because the aha moment for me reading this was just realizing that for years, these specific scans were basically exempt from the standard report card.
That really is the crux of it. I mean, in medicine, we love data. We love auditing performance. We want to know if we're doing a good job.
Of course.
But for this one type of MRI, the system was just set up in a way that made auditing almost impossible.
Okay, so let's get into the weeds of why that is. Because it seems so counterintuitive. It all comes down to a label called Category 6, which to me sounds like a hurricane classification or something. But in the BI-RADS system, what are we actually looking at here?
So BI-RADS stands for Breast Imaging Reporting and Data System. It's the universal language radiologists speak. Every scan gets a number code.
Like Category 1 is all clear.
Category 1 is negative, all clear. Category 2 is benign. Category 4 or 5 means we're worried and, we need a biopsy.
And Category 6?
Category 6 is reserved for known malignancy. It means the patient has already had a biopsy, we have the pathology report in hand, and we know for sure there is cancer in the breast.
Okay, so let's trace the journey. I've just been diagnosed. My surgeon orders an MRI to map out the surgery. That MRI is automatically stamped as a Category 6.
Correct. And while logically that makes some sense, the main question, is there cancer, is already answered.
All right, guessing anymore.
Right. But here is where the loophole opens up. Historically, the national audits that track how good a radiologist is, how accurate they are, they just exclude Category 6 exams.
And the logic there was, why audit a test when we already know the answer?
Exactly. It's like taking a test where you have the answer key right there. You don't get points for finding the cancer that everyone already knows is there.
So the data collectors just skip them.
They just skip these files entirely. They weren't part of the quality control pool.
But that misses the entire point of why we do a preoperative MRI in the first place, doesn't it?
It does.
We're not doing it to confirm the cancer we found on the mammogram. We know that's there. We're doing it to see what else is there.
Precisely. We are looking for the extent of disease. That's the key phrase here. Is there a second tumor hiding 2 centimeters away? Is there something in the other breast that the mammogram missed?
And because the whole file was just stamped Category 6, if a radiologist missed that second hidden tumor, it wasn't tracked.
It was a complete data blind spot. You could, in theory, be missing secondary tumors, and there was no formal mechanism to flag that as a performance issue in the big national audits.
Wow.
And the new BI-RADS v2025 manual is finally fixing this. It introduces a specific recommendation to audit these exams to see how well radiologists are finding that additional disease.
Which is huge for the patient. Because if you miss that second tumor, the surgeon goes in, takes out the lump they know about, and
leaves the other one behind. That is the nightmare scenario. We call it positive margins, or worse, a recurrence down the line because the cancer never really left.
The surgeon needs a perfect roadmap.
Exactly. If the map is missing a road, the surgery fails.
So this MD Anderson study was basically a test drive of this new audit system. They wanted to see if it was even possible to track this stuff. And reading their methods, it sounds like a massive logistical headache.
Headache is putting it mildly. This was a retrospective study, meaning they looked back at old cases.
From when?
From January 2021 to December 2022, they pulled 1,533 preoperative MRIs.
And these were all women, median age around 54, just diagnosed with, invasive ductal or lobular carcinoma.
Right. But the problem was, because of that Category 6 issue, the computer systems didn't have the data ready to go. There was no button to press that said, show me additional findings.
The computer just saw known cancer.
Exactly. So 7 radiologists had to sit down and manually review the reports for every single one of those 1,533 cases. They had to, reconstruct the past.
And they had to read the text of the report and retrospectively assign a BI-RADS score of 4 or a 5 to specific findings, acting as if the new 2025 rules were already in place.
They did, and the study mentions this took
141 hours of combined work.
141 hours, which brings us to the feasibility part of the title. I mean, that's nearly a month of full-time work for one person.
It's about a minute per case, which sounds fast, but when you multiply it out.
Yeah, in a busy hospital, asking radiologists to find an extra 141 hours just for data entry, that's a very tall order.
It really highlights that while the concept of the audit is necessary, the mechanics of doing it are, well, they're painful.
But they put in the work and they got the numbers. And this is where it gets really interesting. They established 4 key metrics. Basically, a new report card for this type of MRI.
So these metrics are going to be the new benchmark.
That's the idea. Before this study, we were kind of guessing what good looked like for preoperative MRI. Now we have some hard data.
Okay, let's break them down because this really explains the radiologist's mindset. The first one is the abnormal interpretation rate, or AR.
Right. This is the raise your hand metric. It measures how often the radiologist looks at the scan and says, hold on, I see the known cancer, but I see something else suspicious too.
And the result in the study was 30.3%.
So roughly 1 in 3 women who go in for the scan are told, we found something else we need to look at.
I want to pause on that. 1 in 3. If I'm a patient, I've just been diagnosed with cancer, my world is already spinning. And now, days before surgery, I'm told there's more. That is incredibly stressful.
It is high, and the psychological impact is real. But you have to view it through the lens of the surgeon and the radiologist. If there's even a 1% chance of a second tumor, they want to know. So the sensitivity, the willingness to flag things, is tuned very high.
Which leads us right to the second metric, and this is where I think the controversy always is. PPV2, the positive predictive value of biopsy recommended.
In plain English, of the new spots you flagged, how many were actually cancer?
And the number was 22.8%.
Yes.
Okay, so if a radiologist flags 100 new spots and says, we should biopsy these, almost 77 of them turn out to be nothing, just benign noise.
Yes. And if we were talking about a screening mammogram for a healthy woman, a number that low would raise some serious eyebrows.
You'd want a higher hit rate.
For sure. But the authors argue, and I really agree with this, that the context here is totally different. The cost of missing it is so much higher.
Better safe than sorry.
Exactly. This is the better safe than sorry metric. In a preoperative setting, you are aggressive. You would rather biopsy 4 benign things than miss 1 malignant thing that changes the entire surgery.
So a low percentage here isn't a sign of bad doctoring, it's a sign of high vigilance.
That's the argument. You are trading efficiency for safety. You are accepting a higher false alarm rate to ensure you catch the real threats.
Then we have the metric that justifies all this stress and all these biopsies, the ACDR, the additional cancer detection rate.
This is the headline number.
This is the answer to. Did we actually save anyone from a botched surgery plan?
And the result was 90.7 per 1,000 exams.
So about 9%.
Nearly 1 in 10. In almost 10% of these women, the MRI found a second cancer that the mammogram and ultrasound had completely missed.
That stops me in my tracks. 9% is not a small number in medicine. That's 1 in 10 women whose surgical plan might have been completely inadequate.
It's massive. That could be the difference between a lumpectomy, just taking the lump out, and needing a full mastectomy because the disease is actually widespread, or finding cancer in the other breast.
And speaking of the other breast, the study broke that down by location, didn't it? They used ipsilateral and contralateral.
Right. Ipsilateral means the same breast as the known cancer. Contralateral means the opposite, so-called healthy breast.
And the findings were not equal.
Not at all. The detection rate for additional cancer in the same breast was 62 per 1,000. For the opposite breast, it was about 35 per 1,000.
So you're almost twice as likely to find a second tumor in the sick breast.
Yes, and when they looked at the odds ratio, which sort of measures the strength of that association findings in the same breast, were significantly more likely to be malignant.
And that supports what you call the sick lobe theory.
It does, yeah. It's this idea that breast cancer isn't just a random lightning strike at one tiny point. It suggests that the whole region of tissue in that breast has undergone changes that make it unstable. So if you have one tumor, the tissue nearby is essentially primed to make another one.
Yeah, it makes sense. It's like
Yeah.
if you have mold on one slice of bread, the slice next to it is probably at risk too.
A grim analogy, but an accurate one. The environment in that breast is just more hospitable to cancer.
They also found an age factor, right?
They did. Older patient age was associated with a higher likelihood that a suspicious spot would turn out to be real cancer. The odds ratio was 1.04. It sounds small, but it's statistically significant.
So as patients get older, we worry a little more that those extra spots are the real deal.
Exactly. Whereas in younger women, they might just be hormonal changes or benign cysts.
Now, there was a technical quirk in the audit rules about lymph nodes that I think is important.
Ah, yes, the axillary lymph nodes,
Yeah.
ones in the armpit. We often see that the cancer has spread to those nodes. It's vital information for staging.
But for this specific report card, those didn't count.
Correct. The new BI-RADS manual is very specific. This audit is for detecting breast lesions, tumors in the breast tissue itself. So if you find a positive lymph node, that's great. It helps the patient, but it's excluded from the calculation of the additional cancer detection rate for this audit.
And why is that? Is it just bureaucratic?
No, it's about keeping the data clean. They want to measure one thing: the radiologist's ability to find hidden tumors in the breast. Finding a metastatic node is a slightly different skill set. Mixing the two would just muddy the waters.
Got it. I want to circle back to the feasibility problem, the 141 hours of manual work. The authors didn't just drop this problem on us. They did propose a solution.
They did. They recognize that you cannot ask clinics to do this manually. It's just not sustainable. We need automation.
But the computers are confused because, as we said, everything is just labeled MRI breast.
Exactly. If you look at an electronic medical record system like Epic or the dictation software, they often don't distinguish a preoperative MRI from a screening MRI.
So the computer can't tell which ones need this special audit. It's flying blind.
Right. So the authors suggest a fix that is, well, it's frustratingly simple.
A label.
A label, just standardizing the exam title to include the word preoperative. If you add that tag, the software can scrape the data, filter for the Category 6 patients, and run the audit automatically.
It seems so obvious. Why isn't it happening?
Welcome to healthcare IT. I mean, we have MRI machines that can see inside the body with magnets, but getting the billing software to talk to the clinical software, it's a monumental challenge.
So this study is kind of a call to action for the vendors and administrators to just fix that drop-down menu.
That's a big part of it. Until they do, we're stuck with the manual method. But assuming we get the software fixed, this study gives us our first real benchmarks.
It anchors us. Before this, if a radiologist had a 30% callback rate, we might have said, whoa, you're overcalling it. Now we know.
No, in this context, 30% is normal. If you're finding extra cancer in 9% of patients, you're doing a good job. But you have to be so careful not to compare these numbers to, say, screening MRIs.
Absolutely. If you had these numbers in a screening program for healthy women, you'd be fired.
Yeah.
You can't tell 30% of healthy women they might have cancer.
The whole system would collapse. But the pretest probability here is different. These women have cancer. The rules just change.
The study also highlighted a specific type of cancer that really benefits from this lobular carcinoma. I've heard you call this the sneaker of breast cancers.
Invasive lobular carcinoma, or ILC, it is so tricky. On a mammogram, it doesn't always form a nice, round, white snowball. It grows in single-file lines of cells, almost like a spider web.
So the X-ray just looks right through it sometimes.
Often, yes. It can be incredibly subtle. But on an MRI, it lights up. The contrast dye makes it visible.
So for a patient with lobular carcinoma, this audit and this scan are even more critical.
They're vital. Lobular cancer is notorious for being multifocal, showing up in multiple spots, or even bilateral. MRI is the best tool we have for defining the true size of the enemy in that specific scenario.
It sounds like we're dealing with a bit of a Goldilocks problem here for radiologists.
That's a great way to put it.
If they're too conservative, too afraid of being wrong, they miss those satellite tumors, and the detection rate drops below that 9% benchmark.
And the patient gets a surgery that fails to clear the cancer.
But if they're too aggressive,
Then the positive predictive value tanks. You end up biopsying benign cysts, causing delays, physical pain, and, as we talked about, sheer terror for the patient, just to find out it was nothing.
so the study seemed to suggest that because of this tension, we might need to accept a wider range of normal for these metrics.
Yes, the sweet spot is much wider here. The goal isn't to hit one perfect number, but to use these audits to make sure you aren't drifting into the danger zones on either side.
So pulling this all together, we've got a new manual coming in 2025. We've got this MD Anderson study proving that, yes, it's hard work, but we can audit these exams.
And I think the big takeaway is that standards are evolving. We are finally closing a loophole that allowed a very critical part of cancer care to go unchecked for way too long.
It's really about accountability.
It is. It's about ensuring that when a surgeon picks up a scalpel, they aren't guessing. They know exactly what they're dealing with. And it's about acknowledging that Category 6, that first diagnosis, isn't the end of the investigation. It's just the starting point.
And for you listening, whether you're a medical professional or just someone interested in how this all works, it really shows how data drives safety. That 141 hours of spreadsheet work, that translates directly to safer surgeries for thousands of women.
Absolutely. It turns, I think we got it all into, I know we got it all.
I want to leave everyone with a final thought to chew on. We talked about that trade-off. The study showed a 30% abnormal interpretation rate. So 1 in 3 patients are told, wait, we found something else.
Right. That's a friction point.
But only about 23% of those biopsies actually turn out to be cancer. That represents a massive amount of human anxiety. Imagine being that patient, getting that call days before your surgery. Is the trade-off of finding those 9% of extra cancers worth the sheer volume of anxiety and false alarms generated by that 30% callback rate? At what point does being thorough become harmful to the patient's mental state?
That is the ultimate question in modern medicine. Where is that line between vigilance and overdiagnosis? And I don't think we have a perfect answer yet.
Something to think about. Thanks for diving deep with us today.
A pleasure, as always.
See you next time.